Thank you, Robin. I'm delighted to be here. My name is Aaron Chang. I'm one of the thoracic surgeons over at the University of Washington Medical Center, as well as at Harborview Medical Center, and affiliated with the Seattle Cancer Care Alliance. I wanted to just share with you a little bit about the role of thoracic surgery in the management, helping in the management of patients who have breast cancer. So I thought this is supposed to be an informal session, so we'll have the opportunity to try to answer questions that you guys may have, but I put together only one slide, most as a prep. So really, from thoracic surgeons typically are asked to be involved with patients with breast cancer, primarily, I think, for really three primary reasons. The first is for a diagnostic reason. The second is they have a role in helping patients improve their overall quality of life. And then, perhaps a little bit more controversial, is the role of chest surgery to help increase overall survival. Going to the first part, the diagnostic part, patients with a history of breast cancer, sometimes in the identification, is that better?
I think it's the fact that you have two mics side by side. So.
Sure. Just let me know if you can't hear me, and I'm happy to speak up a little bit louder. So in the first role, where thoracic surgeons are asked to participate in a diagnostic role, it's really oftentimes in the setting of a patient who has been diagnosed with breast cancer, and as part of their workup, they're also found to have a lesion in the chest, in the lungs. As we all know, breast cancer can metastasize to the bone, the lungs, the brain, but oftentimes in this setting, it becomes a question of trying to accurately stage the patient who may have this lesion. So surgeons are oftentimes asked to evaluate this because not all lesions in the lung are necessarily going to be a metastatic lesion from breast cancer. These could be a benign lesion. It could be a different type of tumor, like a primary lung cancer. And so the involvement of a thoracic surgeon is valuable here in helping make a diagnosis. Oftentimes we do have radiographic imaging that may suggest one way or the other, but again, tissue diagnosis is often very important. And traditionally, the way that we did this was through an open approach, which meant an incision in the patient's chest, a large incision in the patient's chest, and then removing that nodule or those nodules that were there with some surrounding lung tissue. I don't know. Let's see if I can. Okay. Well, anyway, and so there are better approaches now. Now that's Ray to do that, and really they've been around for the last. That's the key for me to step down. Anyway, there are thoracoscopic approaches where we're able to use cameras and smaller incisions to be able to localize these lesions and remove them with a minimal amount of tissue around it, and help our pathologists and our oncologists determine what this actually is. And so these approaches, we call that the video-assisted or thoracoscopic approach. The alternative approach to that is also now we're able to use robots, and so that is also a less invasive approach than the traditional open approach where we had to make a big incision and it was oftentimes uncomfortable for patients. Sorry.
Try again.
Is there a way to perhaps get back to the other slide? Let me just see. Oh, there we go. Perfect. Okay, awesome. Sorry about that. I think Jed will probably talk a little bit about the interventional bronchoscopy approaches that are even less invasive in the sense that they're able to sample a nodule or lesion in the lung by going through your airways and using navigational bronchoscopy. So the diagnosis is oftentimes an important role for why thoracic surgeons may be involved and asked to be involved in a patient's care who has a history of breast cancer. Alternatively, probably more common is in patients who have stage 4 breast cancer where there is metastatic disease. Oftentimes patients, it's the role of surgeons to try to improve overall quality of life and to try to help with symptoms. And some patients who have breast cancer can develop effusions around the lung, the fluid collection from what we call a pericardial effusion or pleural effusion. Pericardial effusion is effusions around the heart, but the pleural effusions can compress the lung such that the patients have shortness of breath or they have trouble breathing in doing just their daily activities. And so Oftentimes the treatment there is to remove that fluid, and depending on how quickly the fluid reaccumulates, you may have to have repeated sessions where you're removing the fluid through a technique we call thoracentesis. Well, that obviously encumbers the patient because they have to come to an outpatient place to get it tapped every time to get it drawn out. So oftentimes thoracic surgeons are asked to get involved because we can help drain that fluid more effectively and more durably through procedures that we call a pleurodesis, or even placing a indwelling catheter that is externalized through the skin, kind of like a port that patients then can go home and drain when they feel that they become symptomatic. The most effective way that we know to do this for patients who have these pleural effusions, malignant pleural effusions as we call them, is to do a thoracoscopic approach where you, again, using small incisions under general anesthesia, patient is asleep, and we remove the fluid and then we instill talc inside the chest wall to try to allow the lung and the chest wall to sort of obliterate that space so that that fluid doesn't accumulate. And this is actually quite durable in terms of providing good symptomatic relief for patients who do undergo this procedure. The downside is that it does require an inpatient stay. It does require a chest tube for part of that time, and it relies upon the fact that the lung needs to be able to expand up against the chest wall in order to completely obliterate that space so that the fluid doesn't reaccumulate in that potential space. Alternatively, one can also do an indwelling pleural catheter where a drain is put into the pleural space, and then you have apparatuses where you hook up the drain at home and drain the fluid if you start to feel symptomatic because of accumulation of fluid. And that's a nice procedure as well. It can be done as an outpatient, oftentimes by our interventional radiologist, or as thoracic surgeons, we like to do things more directly so we can actually see inside the pleural space and lay the drain. So for us, it's oftentimes an operative procedure, but it's an outpatient procedure. The downside to that procedure is that you're leaving something that is potentially could be an infectious source. It does require ongoing management, and sometimes over long term, there can be problems with the drain itself. The other reason that we oftentimes get involved is sometimes there's the metastatic lesions from breast cancer can go to the airways, and they can actually occlude some of the airways. And so we're asked to provide a procedure called rigid bronchoscopy or flexible bronchoscopy, in which we actually go in through your airways while you're asleep and actually remove some of the tumors so that we can open up those airways to allow the lung to re-expand and for folks to breathe better. The final area that I think that is what I mentioned was a little bit controversial is the idea of individuals who do have stage 4 breast cancer, who have lesions that are to the lung, and the idea of removing these surgically in an effort to improve and increase overall survival. And this is what we call pulmonary metastectomy. The reason it's controversial is that initially it was thought that whenever patients who had lesions from breast cancer that had gone to the lungs, that this was really a systemic disease and there was really no valuable role for a patient to go to surgery. And so what has been found, however, is that the biology of tumors, of the improvement overall in our treatment modalities has really increased overall survival, and surgery actually may play a role in patients who have limited burden of disease in the lung, and being able to remove that, along with figuring out the adjuvant therapies, the additional chemotherapies and hormonal therapies for patients in breast cancer. This actually may overall increase overall survival. And some of the small series of institutional studies have suggested that when you just compare individuals who have lesions to the lung that are treated with standard chemotherapy and compare that to individuals who are able to undergo removal of those lung lesions and have control of the disease elsewhere, that the overall survival is quite significant in terms of somewhere between a year to 2 years versus a survival of up to 5 to 8 years in highly selected patients. And so I think that there's increasingly a role for the management as an adjuvant role for surgery in patients who have metastatic lesions to the lung and breast cancer, but this requires a sort of a multi-disciplinary approach to this, because we still haven't truly figured out which patients are going to benefit from surgery, and which patients may just benefit from having more systemic therapy themselves rather than, and it's not that so much that the surgery provides so much a durable increase in overall survival, rather it's selecting for those patients who would otherwise have a increased survival because of the biology of the tumor itself. So with that, I'll hopefully be able to answer more questions and expand on that if you guys have questions.
Ray, I think you're up next.
So, my name is Jed Gordon. I'm an interventional pulmonologist. I'm at the Swedish Cancer Institute, and I'm actually in the division of thoracic surgery. So, I don't want to take a lot of time and go back over things that have already been done, but I didn't prepare any slides. I was told that this was more of an opportunity for me to be open mic and sing, but the semicircle format is very well suited to me. My area of interest is particularly in dealing with people who have the disease burden of fluid that's around the lung that we just alluded to a couple of minutes ago. And so what I hope maybe if this is an area that's of interest to some people, we can talk about this a little bit more in depth. But I'd like to sort of, for those of you that don't know, give you sort of a little bit of an overview of this in just a couple of seconds, because we heard a little bit about it. But for those who don't know in the room, so the lung is like going to the grocery store and getting your groceries in a double plastic bag. And fluid doesn't develop in the lung, it develops around the lung in these two plastic bags. We hear so much the term fluid on the lung, fluid in the lung. But the reality is that in this circumstance, if you imagine these two plastic bags, the fluid gets in there. And the fluid just takes up space, and the fluid pushes the lung out of the way. And this makes people uncomfortable. It can decrease your appetite because it presses down on the diaphragm, and it sort of impacts people's quality of life. So, you know, I think that discussions of techniques and different modalities are really important. But I think really the issue is the fact that you need to be engaged with your clinicians. And the most important point I think that came out that we just heard is this notion of multidisciplinary. And that there's a lot of people that are going to be involved in the management of disease. Because while you're doing this, there's questions about chemotherapy and what impact do these managements have on chemotherapy. Can you get chemotherapy while I'm doing this? And that there's a lot of people and a lot of overlap. And hopefully, through these types of panel discussions and the care that you're getting, you'll recognize that there's really a lot of resources and a lot of people that can help with that. So I'm going to touch on just really a couple of issues that are near and dear to me. So this is unpublished data, which I think you really need to always take with a grain of salt, but this is something that we're working on, just presented at an international conference and hope to publish soon. For people who don't have a directed management strategy for their fluid that builds up around their lung, on average in our series of about 400 people, it was 64 days before there was definitive therapy, and that was managed in a way that returned them to independence. If there was a more multidisciplinary approach in coming up with a more determined strategy for it, it was about 2 weeks, about 16 days before people had a strategy that returned them to independence. Doesn't mean that the fluid goes away. It just means that there's a strategy that those individuals felt was important to them that returned them to their independence. So the goal that I would say for managing many of these things is the notion of returning to independence. And the people that have the disease are the ones that get to decide what independence means, and working with your clinicians in order to find what that is. It's not for me to tell you that one modality is the modality, because it may not be the modality for you. I see people who want to come back to my office every week. Part of that obviously because of my guitar playing and awesomeness. We're trying to work on the complete spa experience, manicure, pedicure, fluorescent Jesus, all the time. Yeah, so.
And singing.
Yes.
Yes.
I'm sorry, this is not supposed to be an advertising episode. But in seriousness, I think that this is an opportunity for everyone to work with their clinical team in order to find what's right for them. So hopefully we'll have an opportunity to talk more about pleural disease. It is something that's near and dear to me, and finding ways. The last thing I'll say about it is that I believe that cancer in general. That was just cut off. Cancer in general is a very personal illness, but it's also a family disease. My mother is a breast cancer survivor. I think the family is very important in involvement with this. And pleural disease is no different. It's something that requires often a support system in order to help people. So another thing I think that's important within the realm of this type of disease is talking about specimens. And oftentimes specimens come from the lung. In the last session we heard about genetics and the importance of genetics. Well, they can only do genetics if they get samples. And so there's opportunities on the surgical side to get samples. There's opportunities through the airway with small needles to get samples. There's opportunities to navigate out to the periphery. So again, hopefully we can get to this more if people have questions. The thing I would caution you the most about medicine in general is that all you have is a hammer, the whole world looks like a nail. There are multiple different ways to get things, and it's not just the technique that the person in front of you does, it's the best technique again for you. Everything has risks, everything has benefits. I'm sure that everyone in this room who has breast cancer has had a procedure. And I'm sure that someone told them at some time that that was a minor procedure. Right? So everyone is familiar with a minor procedure. Right? So every procedure for the proceduralist is often minor. Every procedure for the person having a procedure is major. And so I think that this is something that we all need to be sensitive to and be able to explain why things are important. So hopefully that's also something that we can get to later on in the discussion. And central airway disease was touched on. This is also a major problem, very infrequent. We can certainly talk about pros and cons of that as well. So hopefully that just leaves some discussion points as we leave the lung, and I'll pass it on. Those that can't sing, bring slides.
Absolutely true. You don't want to hear me sing. My name is Ray Young. I work at the University of Washington. I'm a surgical oncologist and basically deal primarily with hepatobiliary diseases. So we created a liver tumor clinic about 18 years ago and met some of you in the audience over that time. So the themes and principles that you just heard in lung disease related to breast cancer applies to the liver as well. The liver is just a little bit south of the lung. In fact, it's just one layer down below the diaphragm. And so instead of going through all this, I want to leave time for question. Most of the time, by the time they come to see us in our specialized liver tumor clinic, your clinicians have already decided that in this particular situation, perhaps some liver-directed therapy may be beneficial. Implicit in that is a lot of things that we don't talk about, because most of the time, when the breast cancer spreads to the liver, it is systemic, it is widespread. So there's no point in focusing in one area versus the entire body. However, in some patients, the disease is predominantly in the liver, and everything else is quiescent. For example, the bone mets is well taken care of, stable. The small pulmonary nodules have been there for a couple of years, hasn't changed. But the only thing that's different is this liver lesion that is slowly changing. What should I do? So the bottom line is tumor biology, as stated earlier, is king. It drives everything. It dictates how well you do or not do. In the interim, our role in terms of the liver is to try to mop up or consolidate some of the things that are left behind, usually after systemic therapy. And shown here in the next slide is the many different options that we have to target a particular lesion or lesions in the liver. And I'm not going to go through all of them. The reason I list them is because all these things is because it is very complicated. Been doing this for a couple of decades. I still can't remember all of these options at one time. So what do? We bring the group together. As stated before, we always meet as a multidisciplinary team on every case to come up with sort of the best options for the patient. So this is, I guess, is a way of defining precision medicine or personalized oncology.
it's not one necessarily better than the other. It's just we have to tailor it best for you. Okay? And some of the modalities, yes, the overriding theme is for us to be able to get rid of the disease as best we could. So that's from the oncologic side, to get rid of the cancer, but at the same time to preserve the function of that organ, in this case, the liver. So it is that combination that we take into consideration in every case. And try at the same time to predict, even if I take care of this, what's going to happen in the next 6 months, a year. Okay? For example, if you have a lesion in the liver, technically I can take off a big chunk of your liver. The liver would regenerate and you'll be fine. But we know that this disease can come back, often do, in the liver again. Then what do we do? Well, so we think ahead and say, well, rather than removing all that functional liver, let's preserve as much as we could, because we don't know when the next lesion is going to, when and where, right? So on the note of personalized oncology, you've heard a lot of that this morning. We do genetic testing and all. I just want to bring up one thing that we are, this is so common that we are actually created a center for minimally invasive oncologic therapy to the liver. One other thing that is not quite ready for clinical delivery, but is close. So you do genetic analysis, as you see here, and we do a whole bunch of big data analysis to come up with targets. And many of you know, well, if you have HER2 amplification, or if you have RAS, or you have this, then we can give this, this, and this. But all that really is just, in my opinion, an educated guess. So you're trying to get an idea of all the medications out there, which one works the best, right? So we have developed recently, and this is research, okay, so this is not, you cannot get this done right now, but we can take any tumor. We haven't done it for breast, we do it for other things. Because I'm a liver surgeon, I take it out from liver. Acquire that tumor, keep it alive. We can do that, and then interrogate it. So you can say, well, my oncologist thinks this drug, that drug, or a whole list of them would work. The question is, which one works better relative to each other? So as many of you know, cancer is very complicated. When you look under the microscope, it's not just the cancer cells, not just the stromal cell, the endothelial cell, immune cells. There's everything living together under one roof. And that is how the cancer progresses, right? So the way we have it is that we preserve all those elements in this original context, and then we can test. Okay, so this is an experimental platform, but I'm sure there are many others out there similar to this. I'm hoping that in time, the patient will benefit by directly testing your cancer.
So I think I'm the last panelist. So my name is Shilpan Patel. I've been on faculty for 10 years with the university, the Seattle Cancer Care Alliance, the Hutch, the Northwest Hospital and Proton Center up there, and Harborview as well. And I sit on faculty in both radiation oncology and global health. And so my area of focus is really thoracic and GI cancers. So I feel like hopefully I can help tie some of this stuff together. And I can't emphasize enough some of the points that have been made here in terms of focusing on finding a good multidisciplinary team where you have really experts kind of across the field. And I'd say it's been really nice to work with people like Aaron and with Ray and also with Jen actually over at Swedish. And so I think it's really important to find that kind of team. I didn't really prepare any slides either. I had heard there was going to be some karaoke, so but maybe we'll save that for lunch. My dreams of barbershop quartet are now dead, apparently, because two of the people here can't sing. But, who knows? We'll see how it goes. Maybe Jen and I'll be doing a duet during lunch today instead. But radiation therapy has been used for over 100 years in lots of different ways. There's lots of different ways that we can use it in breast cancer and in the metastatic setting as well. There's two big ways that radiation therapy is delivered. One is brachytherapy, where we're able to take a radiation source and put it directly at where the cancer is, and then the radiation source is then taken out. And then there's also teletherapy, which is a more common way, which is where we use protons or photons from the outside. We can use it in the palliative setting, where we treat just a very short course of therapy, say over 10 treatments, just to alleviate symptoms. More recently, I would say over the last 15 to 20 years, we use it in something called stereotactic body radiation therapy. And so I direct the stereotactic program at the university and have for the last 10 years. And so it's really exciting, a new technology, I feel like. And 15 to 20 years may seem like a long time, but in medicine, that's actually a relatively new technology. And we found some really high successes where we're able to kind of consolidate radiation therapy into, say, anywhere from 3 to 5 treatments and focus it just at the cancer. And the efficacy is pretty high. In fact, in some of the most recent lung publications, we've seen it as high as 98% control rates. Which is really exciting because patients do not have to get operated on. You're able to come in as an outpatient. They're able to kind of live their lives, come in, get their treatment, and then 45 minutes later, they're going home and back to their regular life. And so it's nice because I think one of the things that is really important, and I think a few people have touched on that today, is quality of life as patients are going through this. We have to, as healthcare professionals, realize that your life can't be completely engulfed by your therapy. There is a life outside of that, and I think we are need to be all very respectful of that. So I'll kind of stop there because I want to make sure we have plenty of time for questions. But I think that I can talk more about it as questions kind of come up. But why don't we kind of open it up for questions and we can have
If you got
discussions.
your card, you can send them to the end, or you can also raise your hand.
I have a question. I was told a few years ago I have stage 4 metastatic breast cancer, I have it in my bones, my liver. I was told though I had it too much or in really bad spots on my liver, so it could be removed. Is that common?
It is very common to have what we call multifocal disease, meaning it's more than one site. And you're right. What we can do to even a small lesion, a single lesion of the liver, depends a lot on location. So each case has to be individualized, but the modalities that I show you can usually, not everyone in the case, address lesions at any site within the liver. So that just has to go through our any sort of multidisciplinary discussion to see what is best for you.
So we have a question on it. Well, you raised your hand first. Why don't you go and then we'll answer the question on the card.
Yeah, I just want to make a comment on your comment about the lung surgery. So I had an isolated lesion to my lung in 2006 and had the entire lung pulled, although it was a battle back then because people didn't want to do it. But I haven't been NED since 2006.
So we have a question that was brought on a card, and I'll read it. It says, barring lots of lung progression, what is longish quality of life for people who have pleurodesis procedure? And I'll just recap for people what this notion of pleurodesis is. So we'll go back to this notion that the lung is like going to the grocery store and getting your groceries in a double plastic bag. The fluid builds up there. If you pleurodese somebody, that is basically eliminating that space, putting an agent in there and having those two bags sear together. So we can both answer that. I'll let you go first.
I think that when you're talking about the quality of life associated with pleurodesis, depending on your approach, the discomfort is with the approach of how you do it. When you do it from a thoracoscopic approach, which requires a general anesthetic, oftentimes from a thoracic surgeon, you do have a short inpatient stay, and we typically instill talc throughout your chest cavity. The idea is that it incites an inflammatory reaction, and then we evacuate the fluid. The reason that we oftentimes value the thoracoscopic approach is that we are able to distill the talc fairly evenly across your chest cavity because we actually can see in there. And we can also see if there's other areas of the lung where it may be stuck that we would try to release in order to allow that lung to fully expand. But there is discomfort with a chest tube. There is discomfort and with general anesthetic and having to be in the hospital. And so those are the short-term, I think, quality of life detractors that one has to take into consideration. You could do this at the bedside. I personally don't do this at the bedside, where you still have to instill a tube in or and spray it there, just because it's a little bit. I found that at least for the patients that sometimes it's uncomfortable, and so I don't typically do that. But certainly, if patients want to do that as an approach, that's something that we would defer to our pulmonology colleagues or interventional colleagues who would be willing to do that. Long-term quality of life, I think, is really dictated, again, by the other treatment that a patient is getting. I think that this is about 70%, 80% effective for patients with malignant pleural effusions in terms of preventing the recurrence of symptomatic pleural effusions. But the long-term quality of life, I think, also is going to be dictated by what other additional chemotherapy or hormonal therapy patient is getting for breast cancer.
So I'm going to follow up on that really fast. So I 100% agree with what was said. So the durability of it actually is very good. But for me, everything starts before the procedure. If you're talking about the procedure, you really need to have had a formal conversation beforehand. So no singular procedure is right for every person. So the issue that has to occur is a discussion, number one, about whether the lung fully expands. If the lung expands, or 90% expands, then I think the question becomes, what's the most appropriate procedure for the individual who's there? And having an honest discussion, because really the question is return to independence and a quality of life that's appropriate for the person who has the pleural fluid. So the conversation has to happen beforehand. What are all the options? Which is the option that's right, and which is the one that has the most high likelihood for success? So while if you look at the literature, the success rate for pleurodesis is about 80%. That's in the middle of studies that say around 70%, around 85%. But if you dig into those studies, there's a cohort of people where actually the success rate is very high. It's very, very high. And then there's a group of patients that should have never had that procedure in the first place. And so that's where these discussions really have to happen. And then I think the question on the back end is, what is the quality of life and independence that each individual person wants? So the durability of the procedure is very good.
So one of the questions we got is, how is radiation advancing to focus specifically on the cancer site and not radiating all the tissue in front and behind the cancer? And there's two really great things that have happened. And so I was in medical school back in the late 90s, and so things have dramatically changed even in the last 15 years. It's kind of surprising. We have a few things that, one of the reasons that I came out here to work is we have the ability to work with lots of different modalities, so whether that is photons, neutrons, electrons, or protons. This is the only proton facility that exists in the Pacific Northwest. I think the next closest one is like in Loma Linda, and then one over is like in Mayo. And so it's great that these new therapies are able to, each of these has different characteristics, and so we're able to kind of just target where the tumor sits, and because some of these things like protons have mass, they actually stop at the end of where the tumor is, and they don't affect the tumors that sit behind them. It's particularly important in individuals like children, where you really don't want any kind of scatter dose for radiation therapy going in other places. But it's also important when there's critical structures there nearby, like the spinal cord, which is important in both the spine and liver tumors. And so we're seeing things like that's really helpful. The other thing is there's new techniques that have come out using arc therapy, as well as, like I mentioned earlier, stereotactic body radiation therapy. We're able to give these high doses of radiation therapy, like I said, very concentrated, where you're able to take 7 weeks of therapy and really shorten it into, say, a week or a week and a half. And these techniques are able to kind of just focus radiation therapy at very high doses where the tumor sits, and really avoid all those surrounding structures. And so a lot of it has to do with some physics calibrations, as well as kind of using collimation to make sure that the tumor is the only area that's treated, and then we're able to stay off everything else. So there's really impressive advancements, and every year there's new stuff that comes out. So I think that that's been something that's been very rewarding to me, because I've just seen side effects go down pretty dramatically in the time that I've been practicing.
So the question I have is, or forward to me is, does fatty liver disease increase the risk of liver metastasis? That's a great question. The short answer is I'm not aware of any evidence that when you have a stereotactic liver or fatty liver, that cancer cells like to live in that environment. That said, it does increase the risk of the complication of treating the liver. So the fatty liver does not regenerate as well, for example. So if we were to go in and remove or radiate a chunk of liver and the rest of it is fatty, its recovery from the treatment will be slower. Now, what causes fatty liver? There are many different things. Okay, it's not just because you're diabetic and have metabolic syndrome and all that, which is the most common association. But many of the drugs that you take result in fatty changes in the liver. But the good thing is, it's often reversible.
To be a tumor clinic patient, do we have to have a oncologist from UW or SCCA? Is that the first question, I think?
Yeah, I think so.
In other words, do we need, to be part of your clinic, do we have to have our main oncologist part of this local group of people? Or can we commute? Is that making more sense?
I imagine you probably have to have an evaluation by at least one.
Well,
because you need to be-
evaluation, sure, but if we still have a main oncologist.
Right. So
4 hours from here.
The answer, yes. So
Yeah,
I
You
did
did it.
it, and I went and saw the liver, but
Okay, thanks.
same here.
I mean, we have patients, because it's the only major academic medical center for 5 states, we have patients that come from all over the country, second opinions all the time.
Thank you.
So,
Who's got a question over there?
So let me just add to that. We sort of try to do a shared care model. We know you have local oncologists and all, but we're here just to a lot of times just give a different opinion or independent opinion, and oftentimes you go back to your local physician for care.
I think there's 2 critical points to your question. One is that, medicine is not personal, it's professional. And so you should never feel concerned or anxiety about getting other opinions about what's going on. It doesn't mean that you have to change your care or anything like that. I think oftentimes, people feel a certain allegiance to an individual or something. This is not personal, this is professional. But I would also agree with exactly what was just said, is that, there's a lot of expertise and there's a lot of need for clinical trials and unique radiation therapies that can only be done at large urban centers. But I would argue that the overwhelming majority of care can be delivered locally, and that the burden on individuals to travel just for name recognition is most likely unnecessary. That doesn't mean that there aren't unique services that people need with unique problems, and there's not unique expertise. But we really need to be concentrating on the things that people can stay local for, they should stay local for. And the things that people need to travel for, you should totally feel comfortable finding the local and regional expertise.
And I would echo that, a lot of times, well, from a surgeon's perspective, it's hard to do surgery at a different place, but a lot of times, local surgeons will ask, and we always provide opinions and say, this makes sense, or this, we would do this different. So we always are willing or enjoy offering those types of opinions. And I would say also that really pertains to, at least with the radiation oncologists and our oncologists, a lot of times they are willing and readily help the local oncologist or the radiation folks to sort of come up with regimens. Because we realize there are a lot of patients that come from so far away, Alaska, from other places, that it's just, really you got to be where your support network is. And that's that's so important for someone that is going through treatment and having that support network. So we really all understand that.
So there's two more questions that we'll just quickly kind of go through, and then unfortunately our time is up. One is proton therapy appropriate for breast cancer? It really depends on the situation. It depends on if there's critical structures that are nearby, also what other diseases that patients have. If they have heart problems, or the breast tumor is going to affect is close to the heart or for some reason, or we'll be treating those nodes, then it may make sense to treat with proton therapy, and so it really has to be individualized, and I think that is something that is case to case. And then I'm not sure I can't read the...
I think that's a question pertaining to our tissue culture system.
Yeah.
But I'm not quite understanding. There are many different...
Rational Therapeutics and Dr. Wiesenthal have been doing, so you know what I'm talking about?
I've heard about it, but I don't know.
Oh, they take your tissues, put it in 30 or 40 different, I don't know, do you even still use, I'm 70 years old, do you still use Petri dishes? Whatever we use now these days. Put your tumors in each dish, take every single chemo, whether it's on the street or in trial or still in the lab somewhere, put them in each dish to see which one affects your tumors as opposed to hers and hers.
Yeah, the
That was
goals
from
of
a
this-
comment that you had mentioned that sounded really interesting on your
Organotypic.
pronounce it, culture.
Yeah, it's very similar in principle. It's just the details of how we come up with the answer is different.
Okay.
Right, so we integrate the big data of the proteogenomic analysis into all.
Is it a study that's opening up for that? Or?
There is a study, but not specific for breast cancer right now, but we hope to expand that in the near future.
I'd like to just speak up for two reasons. One, because I totally appreciate that you guys are focused on I call it the QOL. I need some quality of life here.
Right.
But this nice lady here has spoke up and is asking about her liver meds. And just 3 weeks ago, I think I was in the same boat as you were. I'm young, I'm raising a 10-year-old daughter, and I want options. I don't want to be in a box. I don't want someone to tell me, well, this is how I treat everybody. I have systemic disease, I have it in my bones, but it's so minuscule in my bones compared to my liver, but everybody just wants to treat me as a whole system. And I get that, I understand we have to stop it at the source, but what I've been asking for 2 years, I have liver mets. And all of a sudden this summer, just 4 weeks ago, 2 months ago it started, I had a CT, my mets were 2.5 centimeters, little tiny, I had about 7, and one of them's now the size of a grapefruit inside here. So no one's been listening to me. Although this Wednesday, I'm gonna have the Y90 procedure, so I'm so excited. But I had to scream from the rooftops for someone to listen to me and hear me, because all along I've been saying, why can't you focus on these mets in my liver and wipe them out? And I was repeatedly told, well, that's not really how we do it, you know, because you have systemic disease. I'm like, but my bones are quiet. My bones are not doing anything. And I've got things to do. So now all of a sudden I'm in a panic because there's a tumor in here this big, and it's pushing on things, and I'm miserable. And it was of my own accord that I found a Dr. Docky over in Kirkland or wherever, you might know, that's willing to do this Y90 on me because I'm different than everybody else, because 90 can talk to the other doctors that are just doing everything on a standard basis.
Yes, I agree.
We are learning from you as well.
Thank you.
I mean, I know that everyone is just coming to the room, so I would just like to say for starters, I think it's phenomenal that you'll stand up. So when I said that my mother was a breast cancer survivor, so I never told anybody that my mother had breast cancer. So I spent my junior year in college thinking that I was the only one who knew somebody who had cancer. So I think this forum, speaking up and talking about this and screaming it from the rooftops is super important. I don't have an answer for you, but I'll go back to what I said before. I think that medicine and the power of medicine is enormous. I think the power of communication and our ability to talk to people as people is as powerful or more powerful. And I am embarrassed to say that perhaps as physicians and clinicians, it's a side of medicine that we're not always as good at. So I think all of the yous need to force us as physicians to see people as individuals with individual problems and find solutions.
Amen.
And I think that the onus is on you to make sure that you're comfortable with your clinical treatment setting. Not every setting is right.
So I'll thank this panel. You guys are terrific, and I think we have the coolest panel clearly because we're still going, right?